Do you, Tim, do you want to put your slides in slideshow mode? Great. All right, Victor, let me know when we can get started.
Let's go ahead and get started.
Okay, great. Welcome everybody this morning to January's AIDS Clinical Conference. Very excited to welcome Tim Menza, Dr. Tim Menza this morning, who is an associate professor in the Division of Allergy and Infectious Diseases here at UW and co-medical director of the Public Health Seattle and King County Sexual Health Clinic. And Tim, thank you so much for joining this morning. Over to
Thank you,
you.
Julie. And sorry for being so late. I'm in San Francisco for a training, but things didn't, I didn't get here on time. At least the bus didn't. So no conflicts of interest, some disclaimers that are typical for the AATC presentations. So the things that we're going to do today are we're going to examine the most recent data on the use of doxycycline to prevent STI. We're going to consider some of the impacts on doxyPEP on antimicrobial resistance, and where people are sort of going with ideas around screening and the like with antimicrobial resistance. This is sort of more of like a PSA. We're going to discuss some trends in mpox cases in Washington State and King County. We're going to explore the latest developments in testing and treatment for Mycoplasma genitalium. And then I'm going to sort of show you how to integrate BV partner treatment into your practice to prevent recurrent BV. So let's start with doxycycline for STI prevention. So we have a quick poll, and this might be a review for some people, but the poll is doxycycline for STI prevention is most effective against which of the following STIs? Is it syphilis only, chlamydia only, gonorrhea only, syphilis and chlamydia, syphilis and gonorrhea, or all three equally?
Let's give it up for 5 more seconds.
All right, great. So superstars, we're going to look at this specifically, but it's really syphilis and chlamydia are sort of the most effective or the where we see that doxycycline is most preventative. Gonorrhea a bit less so because there is some tetracycline resistance, and we will review that together. So the first thing I wanted, and this came up actually in Madison Clinic the other day, is looking at doxycycline as pre-exposure prophylaxis, so sort of doxy prep. And there's some there's some data out of Canada and Japan that I'd like to review with you. This first one is it's a daily doxycycline and HIV suppression trial. So this is among men living with HIV for STI prevention. It's called the DADS study. It's among 52 men living with HIV who have male partners in Vancouver and Toronto, recruited between 2020 and 2023, randomized 1-to-1, either to take doxycycline 100 milligrams PO daily versus a placebo. You see the median age there is 43, 21% are Latine, living with HIV for a median of 8 years, most of whom had an undetectable viral load with a median of 5 partners in the prior 3 months. And so 79%, it was a 48-week protocol, 79% completed the protocol, and 70% took more, or they're either 90% or more of their daily doses. And just one person stopped doxy because of worsening GERD. And we saw relative reductions in STI incidence with chlamydia down 92%, gonorrhea 68%, and syphilis 79%. So a small trial, but it looks like among people living with HIV, there's large relative decreases in STI incidence across the board. Now, in a sort of a sister or cousin trial, there's dual daily doxycycline in HIV prevention, or the DUDE study. So this is now looking at people who are on pre-exposure prophylaxis for HIV. And this is looking at 52 men and women who are on PrEP. This is only in Vancouver this time, recruited earlier in 2018 to 2019. Again, another 48-week follow-up study. And in this case, rather than randomizing people either to take doxy or not take doxy, they actually randomized people to a deferred immediate doxy PrEP arm or a deferred doxy PrEP arm. And so 87% completed the 48-week protocol. And at week 48, so at the end, 71% in the immediate group and 62% in the deferred group took 95% or more of their daily doxy. So what we'll do is let's focus just on the red line first. This is the deferred group. Okay, and so by week 24, the deferred group accumulated 19 STIs, whereas in the immediate group, there was an accumulation of 4 STIs. And interestingly enough, in the immediate group, all of the STI incidence was gonorrhea. And so then what's really interesting is then if you look from 24 weeks when the deferred group then starts daily doxy, again, the red line, they only accumulate 1 additional infection, and it's a gonorrhea infection. So from 19 to 20, once people start daily doxy. And so between the groups, there's a relative difference. And also within the groups, there's an obvious pre-post difference in STI incidence in that deferred group who can serve as their own controls before and after. So these are both very small studies, right? Just 52 people apiece in both, but are promising. And we'll talk about particular indications in a second when we talk about this with the next study. So then this is data out of Japan. And in this study, it's now not a randomized controlled trial as the other 2 were, but it's basically a pre-post observational study of 40 women in Japan who trade sex. And they essentially had their STI data before starting, and then they recorded their STI data after starting. And so among the 40 people, 73% took 100% of their daily doxy doses, and the STI incidence pre doxy prep was 232 per 100 person years and decreased to 79 per 100 person years for a relative reduction of 67% in all STIs. And then they also looked at the proportions of people who had STIs pre and post, pre in this sort of lighter gray and post in the darker black bars. And what you can see is overall STIs, there were 10% had an STI in pre doxy prep and 2.6% after initiating. Interestingly enough, there were 2.3% had syphilis, and then no one had syphilis thereafter. And the other thing that they were interested in seeing is there some like vaginal dysbiosis that could be induced by doxy prep? And so they looked also at bacterial vaginosis and vulvovaginal candidiasis, and they didn't see a difference pre and post doxy prep. So then finally, the next and last study around sort of pre-exposure prophylaxis using doxycycline is one looking at weekly doxy directly observed therapy. And so in this, so if you recall, there was the DPEP study run by Janelle Stewart and colleagues here. And that study was looking at a randomized controlled trial, randomizing women to either doxy PEP, so post-exposure prophylaxis. I know I'm switching back and forth here, or no doxy PEP. And they didn't necessarily find a difference in gonorrhea and chlamydia incidence between those groups. But also there was concern that a lot of folks actually had some food insecurity and weren't able to actually tolerate the doxycycline. So a lot of folks maybe didn't take it, so didn't derive the benefit of doxycycline. So when that study was over, they kind of pivoted, which is really kind of clever here. And so what they did is they recruited a group of women, and now it's not randomized at this point, but it's sort of a single arm, and they offered weekly directly observed doxycycline, 200 milligrams. And then they compared the chlamydia incidence in that group to the control arm of the DPEP study. So what they observed is that the incident chlamydia rate in those who were taking weekly doxycycline was 11 per 100 person years. And then the incident chlamydia rate in the DPEP study among people who were not randomized to doxy-PEP, it was almost 30 per 100 person years, for a relative difference of about 61%. And so that's not statistically significant in this analysis, maybe because there's not a ton of people in that weekly doxycycline arm, but I would argue that this is a very clinically significant result. So likely weekly dosing prevents chlamydia among women. So this is kind of really exciting. So now we're going to switch back to doxycycline as post-exposure prophylaxis, and then we'll summarize everything I've talked about around doxycycline in a second. So this is a study led by Chase Cannon here, and this study was looking at the characteristics of syphilis diagnoses among people on doxycycline for post-exposure prophylaxis compared to those who are not taking doxycycline for post-exposure prophylaxis. So these are folks that we're sort of looking back 2023 to 2024. It's April 2023 to December 2024, looking at all the early syphilis diagnoses. And there were 59 early syphilis diagnoses in 56 patients. 14 or 24% of those diagnoses were people on doxyPEP, and 42 were among people who are not on doxyPEP. Early latent was the most common stage at 56%, but then when you break it down between people taking doxyPEP and not, 88% of early syphilis in people not on doxyPEP was primary and secondary syphilis versus 12% in people on doxyPEP. So what that's saying is that many, many more people in the people who are not taking doxyPEP are presenting with primary and secondary syphilis compared to the doxyPEP group, who are mostly presenting with early latent syphilis. And the primary syphilis diagnoses were all confirmed via dark field. And then the other interesting thing about this is that for people who were on doxyPEP, the RPR, median RPR at diagnosis was 1 to 8, compared to those not on doxyPEP, the median was 1 to 32, and that was statistically significantly different. So there's a lot of interesting things we could talk about around kind of what this means, and sort of theories around this. But we're going to be sort of actually looking at a larger study, looking at exactly this in a little bit more detail with a few more centers, hopefully San Francisco, New York, Chicago, and BC, to kind of pool our data to actually assess whether this is a finding that is consistent across other centers and in total around doxycycline and RPR titers. And then the other thing that I wanted to show you was we've also been evaluating the population level impacts of doxycycline on syphilis diagnoses. And in the kind of next 3 slides, they're going to all look pretty similar. This first one is looking at trends in all stages of syphilis in all people in King County, Washington, between 2021 and 2025. So what we're looking at here in the graph first is the observed cases that are reported to surveillance in the blue dots. And then in the red line, this is the model-based, this is like the pre-intervention trend in cases. So it sort of very closely models those blue dots. And then the yellow line represents what's called a counterfactual. It basically represents, what if doxyPEP was never implemented? What would the trend in cases be? And you can see it's sort of very similar to what the pre-implementation trend is, and just sort of continues. And then the green line is what we actually observed after doxyPEP was implemented. And we have March 2023 as the implementation date. It's actually the implementation date in the sexual health clinic, but we're sort of looking countywide. And so what we observed in this one, this is again, all stages of syphilis and all people. In the pre-implementation phase, there were over 6,000 diagnoses of syphilis. And between 2018 to 2020, really cases were pretty stable. After 2021, we saw an increase in cases of 3 cases per month until the implementation of doxycycline for post-exposure prophylaxis. And then post-implementation, we're now kind of looking over to this chart on the right-hand side here. There were a little under 3,000 cases, but there was a decline of 7 cases per month after implementation. So when we sum up all the cases after post-exposure prophylaxis was implemented, and we compare what we what we observed to what the counterfactual would be, whether if doxycycline had not been implemented, there were 3,031 or 52.3% fewer observed cases of syphilis. And now this one, this graph is looking at syphilis trends in men in King County. So similar layout. And in the pre-implementation phase, there were a little over 5,000 cases. Again, stable between 2018 and 2020, but then increased by 2 cases per month after 2021, leading up to the implementation of doxyPEP. After doxyPEP implementation, cases went down 5 cases per month, and compared to the total number of cases that we expected in the post-implementation period, there were 2,248 or 53.1% fewer observed syphilis cases. Now, here's what's really interesting and unexpected was that we also looked among women, and in the pre-implementation phase here, there were 932 cases, and there were a very small increase in 2018 to 2020, and then after 2020, 2021, really one case per month increase up through doxyPEP implementation. After doxyPEP implementation, there were about two fewer cases per month, and there were 755 or 46.9% fewer observed cases than what we would have expected had doxyPEP not been implemented. Now, we also kind of looked at, all right, well, are we also seeing a change in congenital syphilis and syphilis in pregnancy with doxyPEP implementation? And the answer is not really, although jury's still out. We still, the more recent data may indicate a difference. But as you can see here, in 2017 and 2018, there were no congenital syphilis cases. And then there were 23 in 2024. And then syphilis in pregnancy, there were 13 to 14 cases between 2017 and 2020, but then 48 cases in 2024. So I know that was a lot of information. Let's go ahead and summarize the doxycycline piece. So in small pilot studies, daily doxy-PrEP reduces the incidence of all STI. And daily doxy-PrEP may be appropriate for people who have frequent sex, like people who trade sex, or may have another indication for daily doxy. Weekly doxycycline likely prevents chlamydia among women. And people who require T-pallidum on doxy-PEP are more likely to be diagnosed with early latent syphilis with lower RPR titers. At the population level, doxycycline has significant impacts on syphilis, including among people we don't think who are receiving much doxyPEP, like women, but perhaps through shared sexual networks with people who are on doxyPEP. And then syphilis in pregnancy and congenital syphilis have continued to rise during doxyPEP implementation, though most recently there may be some decreases in the 2025 data that we're seeing that are exciting. Okay, I'm going to stop there and just see if there are any questions I can answer about the data I just presented.
There's one question, Tim. For doxyPEP for syphilis, what is the dose in these studies?
Yeah, that's at 200 milligrams after sex. So between 24 and 7, or as soon as possible after sex, up to 72 hours later. Yeah, great. Thank you. All right, so let's keep moving. So now let's talk about doxyPEP and antimicrobial resistance. So Esso and Matt and Christina Thibault here have looked at tetracycline resistance in gonorrhea. And this is sort of looking over time, but also looking with an eye towards what are the effects of doxyPEP on tetracycline resistance in gonorrhea. Okay, so first, tetracycline resistance appeared to increase more rapidly in 2023 with doxyPEP rollout. So there's a red arrow there where the doxyPEP guidelines are released in 2023, and you see these both the blue and orange lines for tetracycline resistance and high-level tetracycline resistance kind of go up. And just some characteristics, tetracycline resistance both low and high level was greater among people taking greater than 3 doses of doxyPEP per month. But as you can see, like, something was happening before that time, right? This is not all doxyPEP, right? So when you kind of zero in a little bit more, we changed some clinical guidelines even beforehand. We moved to use it from azithromycin to using doxycycline for NGU. And as a result, there's been a very large increase, and this started in 2016, a very large increase in chlamydia and NGU among MSM treated with doxycycline, and a very large decrease in azithromycin being used there. And so tetracycline resistance, the high-level tetracycline resistance, actually started increasing in 2020 with increasing use of doxycycline for chlamydia and NGU. So while doxycycline, like doxyPEP rollout, may be sustaining these increases and maybe accelerating them, this was something that was occurring already due to practices related to the use of doxycycline for NGU. Okay, so a question for you. A patient on doxyPEP presents with a skin and soft tissue infection. Would you treat this infection with doxycycline? So answers are yes, doxycycline will cover MRSA, or no, that doxyPEP might lead to resistance in skin bacteria.
Leave it up for another 5 seconds.
Okay, great, good instincts, right? So yeah, let's look at the data. So yes, doxycycline will cover MRSA for sure, but there are some changes in these what we call bystander bacteria. So Staph aureus and group A strep for folks who are taking doxyPEP compared to those who are not. So let's first take a look at Staph aureus. So what we're looking at in this chart is first Staph aureus looking by MRSA, and then tetracycline resistant MSSA, so methicillin sensitive, and then tetracycline resistant MRSA. So in the first column, it's people who use doxyPEP in the last month, and the second column is doxyPEP, people who didn't use doxyPEP in the last month, and then just like a qualitative difference between the two groups. So for just colonization with Staph aureus, we see that there's a decrease among people taking doxyPEP. 27% had Staph aureus on their skin, whereas these are nasal swabs. So 27% were colonized with Staph aureus, whereas for folks who are not on doxyPEP, 36% were colonized. So there's a decrease there of 9%. And then in looking at MRSA, equally, their sort of groups were equal with respect to colonization with MRSA, 1% apiece. But what's different here is that the methicillin sensitive Staph aureus is more likely to be tetracycline resistant in the folks who are taking doxyPEP in the last month compared to those who are not taking doxyPEP in the last month. So an increase there. However, we didn't see the same thing, or the group didn't see the same thing in tetracycline resistance among MRSA. So 1% apiece, so no change there. So the next thing that the group looked at was group A strep. And so in people on doxyPEP, 9% had group A strep, and 4% in the no doxyPEP in the last month had group A strep. So an increase in group A strep colonization among folks on doxyPEP. And similarly, that group A strep was more likely to be tetracycline resistant group A strep, 8% in the doxyPEP group versus 3% in the non-doxyPEP group. So tetracycline resistant gonorrhea is increasing. This increase was likely driven by changes in treatment practice for chlamydia and GU to use doxycycline over azithromycin, but this increase is now likely sustained by doxyPEP use in the community. People who use doxyPEP are less likely to have Staph aureus on nasal pharyngeal swabs but are more likely to have tetracycline-resistant MSSA, but not more likely to have MRSA or tetracycline-resistant MRSA. And people who use doxyPEP are more likely to have group A strep, including tetracycline-resistant group A strep on nasal and pharyngeal swabs. And just a plug for a study that's occurring here and for other cities, it's the Doxia Impact study. So it's a multi-city longitudinal cohort study to look at the real-world effectiveness of doxycycline for STI prophylaxis and antimicrobial resistance, both looking at how the effectiveness with respect to STI rates, how people use doxy, understanding how people, some people continue and stop doxy while some people use it selectively, and then looking at sort of equity aims around, is doxycycline reaching those who could benefit most? And then aim 2 is an antimicrobial resistance aim as well. So if you have patients who might be interested or might qualify, the qualifications are just basically anybody who's had sex with a man in the past 3 months who are initiating or continuing doxycycline for STI prevention, as well as condomless sex with a man in the past year, recent STI testing in the last 6 months. It's a 42-month study, and even if they stop using doxy, they can still participate. So seeking new doxy initiators, as well as gender and racial ethnic diversity across all sites. So there's email there for the particular study, but also Chase is available for info and referrals, as well as the study coordinators at Madison and the Sexual Health Clinic. So one of the other things that I wanted to bring up here, because it's there's a lot of talk about changing screening guidelines, is a study called the Ghana Screen Study. This was a study that was conducted in the Netherlands, and they recruited a little over 1,000 men or sex with men to participate in a randomized non-inferiority trial at 5 centers in Belgium. All patients were screened at 3 sites, pharyngeal, urogenital, and rectal at baseline. And in the control group, only people moving forward, people were screened at all 3 sites every quarter, treating only symptomatic infections. Whereas in the intervention group, which is sort of more intensified screening and treatment, they had the same sort of 3 sites every 3 months, testing, treating all infections, regardless of their symptom status. The primary outcome was the incidence of gonorrhea and chlamydia, and the secondary outcome was antibiotic use. So in the primary analysis, what they saw was that chlamydia incidence was lower in the screening group, the intensive screening group with treatment of all asymptomatic or symptomatic infections. However, gonorrhea incidence was not different between those 2 groups, between the sort of intensive screening group with treatment and then the screening group without treatment or only treating symptomatic infections, likely because chlamydia is more likely to be asymptomatic, detected on screening, whereas gonorrhea is oftentimes symptomatic and would be treated regardless in both of the groups. What's interesting is that then, so that's the top level analysis here. So they found that basically the intensive screening was not non-inferior to screening without, to screening with just treating symptomatic infections, because people did not get the results of their testing in the control group unless they were symptomatic, right? So the other analysis that they did here was they then looked at, so for people with chlamydia in the group that didn't get treatment of symptomatic or asymptomatic infections, if they had chlamydia on one test and then a subsequent test, they also kind of said, well, maybe that's the same infection. So they did some correction for what they thought might be the same infection or persistent infections. And in that analysis, they didn't actually see a difference between chlamydia incidence between the screening and treatment group and the group that only was treated for symptomatic infections. So sort of some takeaways here are that the number needed to screen to detect one asymptomatic case of chlamydia was 11, and the number needed to screen to detect one symptomatic case of chlamydia was 26. And folks received a little over 2 more courses of doxy for every symptomatic chlamydial infection that was prevented. So this group, this Belgium group, and some folks in the Netherlands kind of have been sort of putting out information or their thoughts on how basically Europe is going to proceed, and other countries in Europe are going to proceed with gonorrhea and chlamydia testing. In this particular study, the Belgian folks have now sort of de-escalated routine asymptomatic screening among people on PrEP. And in the Netherlands, interestingly enough, they've discontinued routine chlamydial screening, both in heterosexual men and women. And they really kind of cite this sort of appraisal of the benefits and risks of chlamydial screening, routine asymptomatic chlamydial screening, with the benefits potentially being, but not necessarily borne out, of like, does more intensive screening reduce population level incidence? Perhaps, but it doesn't seem to be a large decrease, at least in the previous trial, and it may not be sustained. And then prevention of chlamydial complications. The data are interesting, with older data really kind of tying up, with strong associations between chlamydial infection and things like PID. Whereas more recent studies, there's a study called the POPPY trial in the UK that really didn't see among women who were screened compared to women who were not screened, the incidence of PID was quite similar. I think 1.3% compared to 1.9%. So there's sort of some uncertainty around the complications related to chlamydial infection. And so they balance that and feel like the harms potentially of overdiagnosis and overtreatment are the infections that we're detecting. Are they viable? Would they go away on their own and not cause any harm anyway? What are the psychosocial impacts of these diagnoses? And so that's kind of where our European colleagues have been moving. And so we're not quite we're not ready to discontinue screening among women or people who have uterus, fallopian tubes, and ovaries. But for our menu of sex with men and people without a uterus, fallopian tubes, and ovaries who have sex with men, we're kind of we're saying at this point in our update to our screening guidelines that routine screening for asymptomatic gonorrhea and chlamydia is no longer recommended. Instead, what we recommend is advising medical providers to use shared decision making to decide whether and how often to screen for these infections. The reasons being is that there's an absence of known sequelae associated with asymptomatic infections in this group of people, the fact that these infections are often self-limited in the absence of treatment, the uncertain impact of screening on population-level incidence, the need to avoid unnecessary antimicrobials, as well as really the high cost of these screening tests that are not often covered by insurance. Now, our goal is not to sort of take screening away from people, but involve folks in the decision-making around screening. So potentially presenting these data to folks or presenting this information to folks and then allowing them to make a decision based on what they think is best for them. And we've implemented this in the sexual health clinic, and we definitely have seen a decrease in the number of asymptomatic screening tests. And there's decisions across the board. Some people want to continue their every 3-month screening or every 6-month screening, but there are other folks who like the idea of I don't necessarily need screening this time, or maybe just doing it every 6 months or every year, or maybe only when I have a symptomatic infection. And that's one thing I want to point out, is that this does not apply to people with symptoms or people who are contacts to gonorrhea chlamydia. Those folks still will get screened regardless. but just a change in the way in which we approach this just routine asymptomatic screening. So I'm curious as to people's thoughts on this. We've had very kind of varied thoughts around this, and so I'm curious to see and whether or not people sort of agree with this and feel like they could sort of present some of this to their patients, and whether or not patients you feel would change their screening practices. We're going to be evaluating this. So Chase, Netta Gilderman, Stephanie McLaughlin are all kind of working on both mixed methods work to both like quantitative survey to look at people's preferences, and then also some qualitative data to interview people around these changes. So stay tuned for that. All right. Have you all seen an mpox case since the global outbreak in 2022?
You know, for another 5 seconds.
Okay, sort of split half and half. All right. So there's also before we move on to this one, there's a good question in the chat, which I failed to mention. So still screening for asymptomatic syphilis every 3 to 6 months? Yes, absolutely. Syphilis is not changing, as well as HIV. Those two things are not changing with respect to the screening. It's just gonorrhea and chlamydia. Great. Thank you for asking that. All right. So what is the situation with mpox right now? So here's, I think the upshot is that mpox is now an endemic seasonal infection in Washington state and nationally. These are the Washington state data. And you can see the global outbreak in 2022 that trailed off, but then you sort of see these little upticks. And you can kind of see them in sort of like late summer, early fall, occurring between 2023 to 2024. And in 2025. And most recently, we had the highest number of cases in King County in a given month since the global outbreak, though very much fewer than during the global outbreak, of 45 cases in September of this year. And so what we're surmising is that there's likely the Pride events, summer travel. Folks are perhaps within sexual networks that they're not normally in, and just more sexually active, perhaps in these time periods, and we're kind of seeing spikes sort of thereafter. And the other piece of this is that we do see that clade 1 is perhaps circulating in community transmission in California. There's also a wastewater case of clade 1 outside of Pierce County in Tacoma, though there was no actual case detected. No one was diagnosed with clade 1. So this is one thing that is an additional concern related to mpox in the United States. Just to review, this is from the National STD curriculum, the mpox lesion progression and timeline sort of over 2 to 4 weeks. And I'm going to just show you just a trigger warning related to some pictures coming up on the next slide. So just some exemplary mpox rash. So these umbilicated papules that can occur on the skin of the scrotum or the penis, in the palate, perianally, on the face. And there was a case in Madison Clinic with tongue lesions of umbilicated mpox diagnosed by Raka. And the most effective mpox prevention tool is vaccination, and that's 2 doses subcutaneously 28 days apart. There's an ongoing vaccine effectiveness study right now, or one that's sort of wrapping up data collection, and a previous one, which was looking at a incredible sort of pull together of all sorts of EMR data, looked at for folks who are partially vaccinated, 1 dose is 36% effective, and 2 doses is 66% effective. Granted, the ranges on these effectiveness measures kind of vary. We've seen up to 90% for 2 doses. So there's probably some variation. So it may be a little larger than that, but this is one of the largest CDC organized studies of mpox vaccine effectiveness. So there's still a lot of people who could benefit from vaccination. As of August 1st, 2023, only 42% of eligible Washingtonians received 2 doses, and 26% received 1 dose. And the other piece of some of these seasonal increases in cases is that some people who are not sexually active during the outbreak may now be sexually active without the protection of vaccine. And that might be greatest among young people. People who maybe chose to change their behavior over vaccination as a prevention strategy may have now resumed their usual sexual activity. And, we as providers, I think and I myself included in here, it kind of fell off the radar for a little while. And so this is a good reminder to keep this as basically just a basic preventative vaccine, just like all the other preventative vaccines we use, just kind of getting folks vaccinated for mpox, like outside of these seasonal increases to ensure that there's protection during. And just, kind of keeping it on your differential, it's out there, it's happening. Also reporting all cases to us, and maintaining a high index of suspicion for any patients with signs or symptoms of mpox, even if, syphilis or HSV might be more likely, co-infections are common, or the patient has been vaccinated, because we do see, the vaccine prevents against severe infection very nicely. But people who are vaccinated can still acquire mpox, though the clinical course is much, much more mild. It can be less severe, subtle proctitis, constitutional symptoms may be absent. And keep clade 1 on your differential, especially if folks are in Central or East Africa or areas of the US, like Southern California, where there's community transmission of clade 1, or if they say they have contact with a clade 1 case. Using mpox PCR, continue to vaccinate eligible individuals. And remember that PEP vaccine-based PEP is available for people with recent exposure, so we can continue to do that. Okay. All right. Dealer's choice in the chat or in the QA. Yeah, in the chat. Do you want to hear about Mycoplasma genitalium or bacterial vaginosis? You probably have time for one of those, but not both. All right, maybe people are ambivalent. So let's go. All right. So let's talk about, let's see.
2 votes for MGen.
MGen. So have you ever tested a patient for Mycoplasma genitalium is the whole question. So yes, no, and Mycoplasma genitalium is an STI? Question mark?
Leave it up for another 5 seconds.
Okay. Yes. All right, good. Yeah, there's a good split here. So yes, 47%, no, 39%, and 14% said Mycoplasma is that STI. So yeah, Mycoplasma is an STI. So yeah, let's do it. This is a very complicated kind of, in my book, it's sometimes the bane of my existence. Anyway, so there's an MGen surveillance study actually led out of the University of Washington with Dr. Manhart. And out of 8 sexual health clinics in the United States in 2020, the prevalence of MGen was 16.6%, with a range of 9.9% here in Seattle to 23.5% in St. Louis. And if you look, this is for folks who are like, MGen is an STI. Yeah, in meta-analysis, it causes things like urethritis, cervicitis. It's associated with PID, preterm birth, spontaneous abortion, infertility, and with some mixed results related to proctitis, although there's going to be one of the MPH students, Mary Gillerman, is going to be looking at that in her thesis project. So, and resistance is very common. Macrolide resistance mutations, 59%, and fluoroquinolone resistance, and this is globally about 13%. So it's an STI, it's fairly common, and it's quite resistant to the antibiotics we use to treat. So here's kind of our rubric for when to screen people for genitalium. And I know this is not always available to everyone. And on the UW side, for here, there's a Mycoplasma ureaplasma PCR, but it doesn't necessarily. There's a lot of interference. So if they pick up ureaplasma, can't necessarily see what else is there. But also, it's not very specific for MGen. And there is a aptema specific for MGen, which we're working with Tao on to actually bring to UW, but it's probably going to take a little bit. But we're hoping to bring that online soon because I know that folks would like to test people, don't always have the ways to do it. And the test we have that's sort of created here isn't the best for MGen. So when to test on an initial presentation. So people with a penis with non-gonococcal urethritis, either acute or chronic. And, sometimes what I'll say, we can't always also diagnose non-gonococcal urethritis in all clinics. At the STI clinic, we can, look at urethral secretions or do a urethral swab and look under the microscope. So we have that benefit. But I know in primary care, in Madison Clinic, we don't necessarily have that at our disposal. So if you suspect non-gonococcal urethritis, or people with a cervix with non-gonococcal cervicitis, again, sort of signs or symptoms in both of those cases. People with signs or symptoms of PID, again, initial presentation MGen is worth testing. For then, there's testing with recurrent or persistent symptoms. That's people with signs or symptoms of recurrent or persistent proctitis or recurrent or persistent NGU or NGC, so non-gonococcal cervicitis, as well as contacts to a partner with confirmed MGen. So first-line treatment in the absence of resistance testing, and really resistance testing is not readily clinically available to make these decisions. So oftentimes this is what we're doing, is doxycycline for 7 days, followed by moxifloxacin for 10 days. And granted, the 10 days in the CDC guidelines, you'll see 7 days. The 10 days is a local recommendation based on cure rates with a little bit longer course of moxifloxacin. Important counseling messages are that to abstain from sex for 7 days following the end of treatment, right? So that's quite a long time during treatment and after. So 17 days with another 7, so 24 days. So that's quite a bit of time not having sex. Treatment failure is not uncommon, is one of the other things that's important to relay to people. And also it's important to refer regular partners, and regular meaning people that people are going to have sex again with, for treatment to prevent infection. And then the important thing is sort of thinking about treatment failure. Patients who test positive for MGen complete their treatment and then return with signs or symptoms of recurrent or persistent NGU, cervicitis, or proctitis should be retested. That retesting ideally should happen at least 3 weeks after treatment to avoid false positive results due to residual MGen genetic material and false negative results due to low organism load from antibiotics that they just took. And in the absence of reinfection, so a sexual partner, sex with a partner who's untreated, or re-exposure, resuming sex sooner than 1 week after treatment, we'd suspect a treatment failure. You can register patients with the Mycoplasma genitalium treatment failure registry. If you have any questions about this, ask me or ask Chase. We're happy to help. But the second line therapy that we use and recommend, and that's been sort of studied in a single arm trial, is minocycline, and using minocycline 100 milligrams PODID for 14 days had a cure rate of 68%. And most folks take all of their minocycline with some mild side effects. But there's folks who also fail first and second line treatments. I won't kind of go through these again. Ask one of us. But tinidazole looks quite promising we're using it as second line treatment, though we're conducting a study in the sexual health clinic of initial treatment with tinidazole to see if that is effective at not only curing but also preventing recurrent and persistent genitalia. So MGen is a common STI associated with several sexual and reproductive outcomes. It's highly resistant to macrolides. Screening recommendations do vary, but we have some that you can use if if those are helpful. First-line therapy should include doxycycline followed by moxifloxacin. Treatment failures are not uncommon. Minocycline is a good second-line regimen, and tinidazole may be promising as an MGen active agent. All right, 1 minute to go. Again, I'm so sorry for being late, and I appreciate y'all sticking with me and being in this noisy cafeteria with me. Um, so thank you. I can stick around for a little bit for questions. You're always welcome to email me. Happy to share slides. Also happy to share the bacterial vaginosis prevention, just because it's super exciting. Just gonna put that up there for you to visualize while we wrap up. So.
Thank you so much, Tim. That was a really great talk, acknowledging we are at the end of the hour, so many people will need to drop off, but thank you for offering to stay a couple of extra minutes, and it would be great to send out slides so people can review the BV ones on their own. Victor put the evaluation link in the box, but let's see if there are any questions. Just saying, please send the slides.
You got it, Laura. All right.
So that was really
Thanks,
excellent,
everybody.
Tim. Thank you. And sorry for your hectic morning. I hope the rest of your day goes a little more smoothly.
Thank you. I appreciate that. All right. Bye, y'all.
Thanks so
Thanks
much.
so much.
All
Bye.
right. Take care. Bye-bye.